Well, thank you very much for your invitation to share our work on knowledge discovery data analytics methods and their potential use in nurse credentialing research. An alternative title from the workshop statement of work could be Developments in Research Methodologies, Health Metrics, and Data Infrastructure to Better Evaluate the Impact of Nursing Credentialing. This has basically been our research agenda for the past 15 years, to use structured data to evaluate the effects of nursing care on patient outcomes. Our challenge has been to produce convincing evidence. And the resource that fuels our knowledge discovery is real nursing data in large data sets. And big data scientists contend that these data sets have potential to produce that convincing evidence. The big data science paradigm is different from classical inquiry. Big data science changes the scientific paradigm from scarcity, exactness, and imposed controls to more messy and good enough, sort of an out-of-the-box thinking here. Having more data means less sampling error, which means we can try to understand and account for the biases inherent within observational data. Good enough means that we can let go of our fixation on causation and learn from what happens in the entire population, giving our attention to description and pattern discovery. And those are the words of Meyer, Schonenberger, and Kukier, who wrote this big data book. They're the ones who call it fixation on causation. And discovering hypotheses that can be tested using classical methods. Nurse scientists have developed data infrastructures to build the big data sets and examine nurse impact questions. The resources advocated by nurse informatics pioneers include nursing data in two minimum data sets, the nursing minimum data set and the nursing management minimum data set. And within these two minimum data sets, we find the necessary variables for our work. This table provides an overview of the nursing terminologies recognized by the American Nurses Association that generate nursing minimum data set variables. And we just heard about ICNP, that's right here, together with the other terminologies that have been recommended by the American Nurses Association. The work that I will share with you is research based on the conceptual framework of the Omaha system and the data generated using the Omaha system by nurses and other clinicians. And this is a conceptual framework diagram or concept map that shows the three components of the Omaha system, standardized terminologies and instruments. So the problem classification scheme suggests that we implicitly believe that patients have health and may have problems with their health, and that we can classify those problems into four domains: environmental, psychosocial, physiological, and health-related behaviors. It also suggests that we believe that we can do something to help people with their problems. That's the intervention scheme, and the intervention scheme tells us the actions that we do about those health problems. And finally, there's the problem rating scale for outcomes, which is Likert-type ordinal scales for knowledge, behavior, and status related to each of the 42 problems. Now, that we could use these in causal models to see if knowledge and behavior and status are related. And we've done that with firefighters and hearing protection study. So these three instruments work together around this core concept of the problem. And the problem list is 42 problems, and I'm explaining this so that you can understand the research that I'll share in the next few slides. We conducted this research through the Omaha System Partnership at the University of Minnesota Center for Nursing Informatics, with funding support from numerous sources, including the NIH, the NSF, and foundations and private donors. And as I share several examples, I welcome you to reflect with me on the power of using the nursing minimum data set and nursing management minimum data set elements and the potential for nurse credentialing research. Well, let's begin with a very big picture question. How do nurses and interventions contribute to variability in patient outcomes? The nurse, the client, the interventions, and the client problems all contribute to variability. That means that to optimize outcomes, we need highly skilled nurses, and the nurses have to know the best intervention strategies in order to tailor interventions. Nurses need a comprehensive, holistic picture of the client's situation. We used nursing assessments to assemble such a picture, with colors representing different problems, shading signifying risk in the rings for 3 dimensions of each problem: knowledge, behavior, and status, and tabs around the outside edge for signs and symptoms related to each problem. These starbursts demonstrate documentation of a comprehensive holistic nursing assessment. And with data mining methods, we're looking for hidden patterns in the data, like needles in haystacks, or perhaps new haystacks, to quote James Hay in the 4th paradigm of research. We found interesting new patterns that we tested statistically. And now, we just created all of these sunbursts for a population of about 200 high-risk mothers served by public health nurses. And we separated them out by the visual appearance of the sunburst. So these brightly colored rings with a lot of gold signify a group that we called bling. And then these darker rings signify a group that we called Dunkin' Donuts. And the comparison statistically between the bling and the Dunkin' Donuts was significant, and what we're seeing here is a bunch of patients who are very high risk with mental health problems. And what we learned is that having mental health signs and symptoms is associated with worse outcomes. And in the next several examples, we'll focus on our analysis of interventions, the dose, the patterns, and the tailoring, and how we can relate interventions to outcomes. So how do public health nursing interventions differ for high-risk mothers with and without intellectual disabilities? Mothers with intellectual disabilities have twice as many problems as mothers without intellectual disabilities. And this is comparing, how we did this is we found 17 mothers in a large data set who had the cognition problem. We matched them 3-to-1 with mothers who had the same demographic characteristics but no cognition problem. And then we did generalized estimating equations analysis on them. And mothers received twice as many encounters and interventions if they had intellectual disabilities. And they showed improvement in all areas, but unfortunately did not reach the desired health literacy benchmark in caretaking parenting of adequate knowledge. So that tells us that these mothers will always need some support. But this study shows that we should advocate for adequate funding levels for public health nurses serving this vulnerable population so that they can have the time, the bandwidth to serve them adequately. We suspect that public health nurses provide complex social interventions, but how do we know this? Well, using graphing methods for unsupervised clustering of co-occurring interventions returned 22 unique intervention clusters, each with diverse problems and actions. We narrowed that down to 14 meaningful clusters that seem to represent particular patient types and acuity. We are beginning to suspect that nurses may tailor interventions to meet particular client needs, but how do they do that? Well, we propose that public health nurses may change intervention approaches as patients improve. And we suggested that problems may stabilize before discharge. Investigating problem stabilization showed that different patterns by problem. As you can see, most of the patterns stabilized right away, long before the patients were discharged from services. However, this caretaking parenting problem never stabilized, which is consistent with the continuous anticipatory guidance given by public health nurses at every stage of the child's development. And the definition of stabilization is that first there's a more intensive intervention period with multiple actions, but then later on the nurse is just checking in using surveillance interventions only. So tailoring by problem seems to be supported. We suspected that we might be able to learn more about this complex phenomenon of nursing interventions using data visualization. In a series of experiments, we were able to test several hypotheses suggested by the data, including the identification of 29 unique intervention patterns used differentially by nurses, although a correspondence analysis test was inconclusive due to low counts in some cells. So we're looking really for the fingerprints of the nurse in the data, and we have some preliminary evidence of that. The nurse's own approach to care. And in these pictures, what we're looking at is intervention frequencies over time by problem. We found some more complex patterns when we compared inductive and deductive approaches to intervention data management for home care nursing. We did unsupervised iterative clustering using k-means and expectation maximization, and that yielded 160 clusters in 5 steps and demonstrated the complexity of home care nursing patterns. It was important for us to note that without the agency identifier present in our first series of clustering, the data mining algorithms were not able to form a single cluster. And what that means is that we not only need to have standardized documentation methods, but we have to use those standardized documentations templates in the same way in order to be able to manage and cluster the data. We found that the data-driven clusters were useful in predicting hospitalization outcomes for frail and non-frail elders receiving home care services. In one of our most exciting studies, I think we nearly reached the ability to talk about causation here. We were able to show associations among patient characteristics, nursing interventions, and patient outcomes. In the sample of 621,000 nursing interventions for these thousands of patients, frail elders were more likely to be hospitalized if they did not receive enough nursing care. In other words, they had low frequencies of 4 skilled nursing intervention clusters compared to receiving medium to high frequencies of those same intervention clusters. Finally, one of my favorite slides of all time, this is a simple display of nurse ratings of health literacy by race and ethnicity, pre- and post-intervention for the common problems found among high-risk parents. Pre-intervention, we note that the patterns are stratified by race and ethnicity, the blue, the red, the green, the purple. Here are the problems: caretaking parenting, family planning, income, postpartum, mental health, residence, substance use, abuse, typical problems found among high-risk families. This line here is the intervention period, and the after ratings show that the pattern changed. We no longer see stratification by race and ethnicity. We see stratification, or we see the pattern change into reflecting what is the problem. What's the most improvement that we see in the postpartum problem? What's the least? The mental health problem, where we see so many challenges with this population. The takeaway message: public health nursing care takes away health disparities. A very powerful message. As we discussed earlier, all this research using observational data is limited by observer bias and the inability to impose controls, and therefore we should be replicating these studies to increase our confidence in the findings. Further research is needed and can address the credentialing question. What is the credentialing effect relative to patient assessment, intervention tailoring, and patient outcomes? All we need are the variables in our data sets. What is the value of credentialing? We can use those nursing management minimum data sets variables to look at contextual factors and the cost of providing a credentialed nurse. We've done some time motion studies that can tell us the value of an intervention, of a 1-minute intervention. Just by doing the observation, we can show you that all these interventions usually take about an average of 1 minute. And in Minnesota, that equates to a nursing salary of about $50 per hour, or $1 a minute. So, looking forward into our research trajectory, examining associations between intervention patterns and client outcomes. Is there a differential effectiveness of intervention patterns for similar client profiles? What is optimal intervention tailoring? What does that look like? What is the nurse effect? How can we quantify that? We need to also try to evaluate patterns across agencies and programs. Do patterns persist across agencies? What aspects of nursing interventions are similar across programs and populations? How does individualized care relate to evidence-based practice? We recommend that we should expand the development of data analytics methods to incorporate nursing and interprofessional data sets and encompass all standardized terminologies and structured data, including nurse and health system credentials, and test these new methods on existing data.
Great, thank you. Our final speaker will be Ellen Marie Whalen, who is a senior advisor at the Innovation Center in the Centers for Medicare and Medicaid. And she is involved in assisting in the design and implementation of delivery system transformation and payment reform initiatives. She previously served as Associate Director of Health Policy at the Center for American Progress, and she will be speaking about new research opportunities building on the momentum of the Affordable Care Act.